I was back in the day before actually I think we were the first class that was actually in the Bayless building. Before that, it was over in the hospital. And I remember my experience was really started with the interview. So John Kusan showed up in a coonskin cap for the interview. That was one. And then I had Dr. Russell's room. It was a small office, and Dr. Russell took up half the room. And I'm sitting in the corner, and I have a great view of Dr. Russell's magazine collection. I'll let you figure out what the magazines were, but it was great. And I kept wondering, is this a test? Should I ask him to close the drawer, or should I? Anyway, it turns out it was all fine. And then Dr. Zook was in the operating room, so he just said, "Come on down to the operating room." So the whole interview took place in the locker room, half of which Dr. Zook was halfway dressed. And at the end, he had a hunting knife that was about a foot long that he just laid there. And I'm like, what is this place? But it turned out pretty awesome, actually. So I'd like to share with you some stories about what I learned from taking a year of burn call. Do we have let's see, is this? Yeah. So I don't have any disclosures. I'm going to mention a couple of off-label uses. Most enthusiasm for new products tends to wane over time, so temper my comments too. So a little bit of background cases, burnout prevention, I'll touch on that a little bit, no pun intended, and a short video to close. So it took almost a whole year of every night burn call. Turned out to be about 347 days actually. So it's a lot of burn call, and we have a busy level 1 trauma center with about 250 to 300 admits a year, about 125 to 150 acute burn surgeries, and 20 to 25 reconstructions a year. The only time I got coverage was when I left town or went to a meeting or went on one vacation. So why did I do this? So our burn surgeon left for greener pastures. Initially, I had the trauma surgeons agree to take some burn call, take half the burn call, and I'd split it with them. And they kind of said they didn't have the bandwidth, so they just did it when they could, or when I was out of town, or when they were forced to. There was institutional confusion, which just basically means we have about 3 different systems in which somebody could be employed in our institution, and nobody could figure out who was going to hire the person. So that led to lack of recruitment. Turns out also that if you want to be voted the physician of the year at your hospital, all you have to do is take about 50 nurses and their family out to a baseball game and give them hot dogs and beer. That's the way to get elected physician of the year at your hospital. And I do have an interest in burns, so it was partly my own fault. But how did we do it? The critical care coverage was good. They took care of all the critical burns that came in the middle of the night and helped me with event management. First 10 years I was in practice, I did my own critical care, but then after we got a new person, I kind of got out of favor of that, and so it was great that they stepped in. The burn nurses were excellent, talented, and then our general surgery residents who rotated with me as interns came back as second years on night floats, so that with a few exceptions, it was rare that I had to do much at night. So a few cases. We had a 47-year-old male general contractor who's working at a remote location on his farm. He lived about 2 hours away from us. We cover a 17-county area. There was somehow paint thinner that was on a bridge that he was building on his property, and it got caught on fire and engulfed him in flames. Got his shirt off, but he had to drive himself in his truck back to his farmhouse, which is about half a mile away. He had about 70% total body surface area, almost all was full thickness. No inhalation injury, but he was very fit and no comorbidities. So this is his back. His whole lower extremities were all burned circumferentially. Groin area, legs. So our surgical plan was early excision, mostly fascial, some full thickness subQ, and a little bit of tangential areas. The initial stages I excised and put allograft on the trunk and extremities. The face we treated with Versajet hydroexcision and ReCell, which is a spray-on skin application. Are you guys using that here very much? I don't know if you have or not. It's pretty good stuff, actually, for the most part. Approximately 2 weeks post-injury, the allograft, we took that off and covered the burns with Novasorb biodegradable temporizing matrix, which is a polyurethane foam. It's a dermal regeneration template similar to Integra. About 3.5 weeks after that, the BTM was stage removal of the silicone laminate, 4-to-1 autograft, RECELL spray everywhere. Eventually, his right distal phalanx developed some Pseudomonas osteomyelitis and required revision amputation, but he survived and was discharged on post-burn day 98. So picture of his hands, pretty much all full thickness. A little bit of BTM on the over the PIP joints there. It looks pretty unincorporated at this time. It got better over time and did incorporate. I'll show you how that looks. So BTM is, I've turned to like that more than Integra because you basically, even though it looks like it's not incorporating here in these yellow areas, you can, if you have fluid under there, you can basically squeegee it out, push it out, and don't give up on it because a few weeks later it'll look like this picture and then these other pictures as it starts to incorporate. And the laminate seems to hold better than Integra because it doesn't the Integra after a while just sort of peels off. But you can leave this stuff on for a couple of months even. Here's pictures as we go forward on the legs. And here he is at 4 months post-burn after 4-to-1 with removal of the laminate, 4-to-1, and then RECELL for the interstices. Here's a picture of his face. So pretty deep burns of the face. He did have some hypertrophic scarring. I've found this to be the case too, where in the beard area, if you get a little bit of hypertrophic scar, they get the beard trying to go through that area and it becomes very thick and hypertrophic. I did have to release his lip, but other than that, the upper face did really well. And especially on the ears, this was pretty interesting to me. This is one of the advantages of RECELL. He had full thickness burn injuries and cartilage exposure. Most of the time this would lead to pretty major reconstruction. And I didn't know what to do because we had so much other stuff to do. I wasn't concerned about the ears at the time, but every time we went back, I would just spray RECELL on the ears and the face and kept doing it. So he had about 4 separate applications, and then you can see how the cartilage covers over. I'm not sure exactly how that happened, but it seemed to work very nicely. And I've talked to a couple other burn surgeons. They've had similar response on the ears. So same thing happened on the other side with exposed cartilage and RECELL application, and nice result from the ears. Here's his hand that I showed you earlier. His range of motion was good, no burn boutonniere deformities. He was readmitted for contracture release of the lip and perineum. Yeah, that was one of the problems because he had so many burn injuries on his abdomen. We couldn't do a diverting colostomy, and his whole perineal area was burned. So we had to go back. That developed a contracture that we released a few months ago, and he's doing a lot better now. And we're doing a series of fractionated CO2 laser treatments on the hands and face at this point. Case 2 is toxic epidermal necrolysis in a transgender patient. So this is a 23-year-old African-American transgender male to female. He started on HIV PrEP, trying to do the right thing with cabotegravir, sustained release injection. About 3 weeks after the injection, he started developing mucosal and cutaneous sloughing. He submitted it for Stevens-Johnson that subsequently progressed to TEN over a few days. Submitted to the burn unit for supportive care and wound care. Derm was consulted. He was started on IVIG and cyclosporin. Don't really use steroids for that anymore. And ophthalmology was consulted. He underwent, we did try RECELL on him. That's the off-label use for RECELL. Seems like it might have helped with his pain, but as I'll show, it didn't really do much for this case. So this is long-active HIV prophylaxis, but it can stay in the body because it's long-acting. I was reading the label. It can stay in the body for up to a year after this. So that'll be important when I show you the end result here. So here's his progression. This is his back progressing through to heal. This is pretty well healed on the right. I'm not sure if you can see all the pictures. That's a month, about 5 weeks after his initial episode of admission. And here's the front. So we did RECELL on the second slide here. And to be honest with you, I didn't really think that it made much of a difference. We were hoping it would decrease his pain and maybe maybe decrease his length of stay and ease his wound care, but it really didn't change anything, in my opinion. Here's his face. So here he is. This is 4 weeks afterwards, and all of the conjunctivitis that he had was pretty well cleared up. There's just a little bit left over, and at this point he was discharged, and he had a lot of family issues, a lot of psychosocial issues going on, so his family wasn't around much. He finally left and went to Toledo, which is several hours away from us. He eventually came back, was doing fine, seemed to be doing okay, and then a couple of weeks later I got a call that he was having trouble with his vision. I'm like, what's his vision? So anyway, it turned out that he never followed up with the ophthalmologist. And so his outcome, his wounds finally closed, initial minimal support at home, followed up at 3 months, continued to improve, failed to follow up with ophthalmology, moved to Toledo, came back 4 months with visual difficulties and had corneal ulceration. They treated that at Ohio State with amniotic membrane, but despite that he had ruptured cornea and has visual impairment that's persisting. So some of my biased conclusions on these are that BTM is better for larger burns, but I still use Integra for smaller areas because you can squeegee out the fluid on the BTM. The Integra doesn't really seem to tolerate that. I think RECELL really does help with healing of donor sites and interstices of mesh grafts, and I really can't see us using CEA at our institution again. It's really it's essentially you're using a patient as their own culture plate for the epithelial cells, so it really works nicely. Multiple applications of the years may avoid the need for major reconstruction, and it doesn't seem to be effective, in my opinion, in TEN. Now, maybe this case was separate because it was a long-acting and may have still had ongoing injury from the long-acting drug that he was on, but it's hard to say. And then laser rehabilitation of scars is real. I'm not sure if you guys are doing this here at your place, but let's see. Does this? No, sorry. Oh. Sorry about that. Let's see if these will run. Oh, there you go. Yeah, so this is a fractionated CO2 laser. I don't know if you can tell, but where we're lasering this entire hand was a full thickness graft at one point, so it really faded out pretty nicely. We're just touching up the areas around the digits at this point. And then we also use, Scott Holtman taught me this, where you put some cortisone, just Kenalog suspension, and after you do the laser treatment, just dab that on, and then we cover that with bacitracin. We do these treatments every 6 weeks for about 4 to 8 treatments. So, am I one of those guys that talks to those residents about walking uphill in the snow both ways? Yeah, maybe a little bit. But how do you avoid burnout in something like this? This is a real issue that people like to talk about in education. So I think the tools for burnout, you have to figure out what works for you. In my case, it's physical exercise, Peloton, and weights virtually every day. I think meditation, mindfulness practice becomes easier when before you go to sleep at night or whenever you pick your time out, there's YouTube videos, and Peloton has meditation things too. I think family and social support are very important. I can't wait every day to get home to see my grandson whenever I get the opportunity to see him and play with him. So those are the kind of things that you have to lean on and lean into as you do this. I think there's basically also this concept of burnout and resilience and how you develop those things. Dr. Russell has resilience and grit in spades. I think all of us can attest to that. But this is kind of looking at it in terms of a cross-sectional thing. Like if you have a lot of grit, then you're less likely to burn out. If you have a lot of resilience, if you have a lot of less grit, you're more likely to burn out. So are grit and resilience the same thing? Not really. Grit is the passion and perseverance towards a long-term goal. And I think that's what you see in somebody like Dr. Russell. It's like somebody who has really loved what he's done over the last many years, decades, we should say. But he kept doing it because he loved doing it. I mean, there's no question. I think that's the people that are really successful. That's what we are. Resilience is different. Resilience was actually studied initially in people who had suffered severe loss, like the loss of a child, loss of a spouse. How do they bounce back from that kind of a situation? So I don't really think of resilience in the same way. Yes, you're bouncing back in limited things, but that's not the original purpose of the resilience studies that they had. So conclusions, I think burnout's less likely to occur if you understand how recovery and to replenish your physical and emotional resources, and that's essentially what burnout is. Burnout is you have your stressors, and then you have your compensating mechanisms, and if those are out of balance, that's when you get burned out. Luckily, that didn't happen to me, and I appreciate the opportunity I have to impact lives, and burns are cool, in my opinion. So this is our guy. This is what gets you going. We get somebody like this home to his family and his 5 boys and his wife who was there every day for him, and kind of want to. This is. Oh, there we go. Oh, you run. You got it. Okay. I don't know if you can hear it or not. We can move that forward a little bit. Yeah, it's about 1.5 minutes, so if you just move it forward to almost anywhere in there, yeah. But here he is walking out, saying goodbye. The whole burn team showed up, and even a couple of the nurses that were not on duty came. And that makes it all worthwhile. Thanks. That's all I have.